side, Dr. Neera Gupta, she is head for medical affairs, Biocon, and Mr. Satish Menon, he is chief strategy officer for oncology, Biocon. So with that, from all three of us, we'd like to welcome all of you for this ad board on impacting lives through impacting cancer care in the new world and fostering effective partnerships. So we have 7 advisors for this ad board, and let me start by welcoming Dr. P.K. Julka. He is Senior Director for Oncology at Max Hospital. So very warm welcome to Dr. Julka. Thank you, sir.
Thank you. Thanks.
Thank you, sir. And we have with us Dr. Ajay Bapna. He is Director and HOD of Medical Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur. So very warm welcome, Dr. Bapna. Thanks for joining in. And we have with us Dr. Poonam Patil. She is Senior Consultant Medical Oncologist at Manipal Hospital, Bangalore. So very warm welcome, Dr. Patil. Thanks for joining in.
Good evening to you all.
Good evening. We have with us Dr. Krishna Kumar Ratnam. He is Senior Consultant and HOD of Medical Oncology at Meenakshi Mission Hospital, Madurai. So thank you very much, Dr. Ratnam, for joining us. Welcome to you. And we have Dr. Imran Nasir Sheikh, he's Consultant Medical Oncologist at KDA Hospital, Mumbai. So a happy Eid to you and a very warm welcome to you, sir. We have Dr. Shailesh Bondade. He's Consultant Medical Oncologist from Apex Wellness Hospital, Nasik. So thank you very much for joining in, sir. Very warm welcome to you. And last but not the least, we have with us Dr. Prasanjit Chatterjee. He's Consultant Radiation Oncologist at Apollo Glenjals Hospital, Kolkata. So thank you so much for joining us, Dr. Prasanjit. A very warm welcome to you.
Welcome.
Thank you, sir. So with that, let's just quickly walk through the agenda. So this is how the agenda looks like. We'll be discussing about the current dilemma in cancer care, which has come because of the new pandemic. Then we'll have a section where we will be focusing on what does it mean for the patients, what it means for the patients in terms of access to hospitals, their treatment options, and the economic impact of COVID in cancer care. And then we'll move to evaluating possible interventions and opportunities in partnerships. So this is how the agenda looks like. So to begin with, this is how the COVID numbers look like. This is a three-day dated number. So around 16.5 million cases in the world and 1.5 million cases in India. So it is increasing on a day-to-day basis. So I was just interacting with one of the advisors now, and he said, I've stopped tracking it also. And I think it same holds good for a lot of people now. It's becoming a part of life, but definitely it is creating a havoc in the entire group. So this is one of the reports which came from WHO in the month of May, in which they surveyed and they found out that when it's primarily they discussed and studied about NCD, and they found that around 42% of the countries reported disrupted services in cancer. So, and India was definitely a part of this, these countries which had reported that. And also it said that many people who need treatment for diseases like cancer, they've not been receiving their healthcare services and medicines because from the time the pandemic started. So I'm sure this data holds true, and it might be different when it comes to disruption in urban as well as rural places in India. It might be different when it comes to a metro city or a non-metro city in India, and it might be different from hospital to hospital as well. These are some of the challenges which the healthcare faced because of the pandemic, which was initially it was about the PPE kits, the testing kits. So maybe to a certain extent those might have been overcome by now. However, hospital beds in many places still remain to be a problem. And non-COVID patients, they were left unattended. They were confused. They did not know where to go. Some of their hospitals where they were going for cancer care, they were converted into COVID centers. Some of the times when they reached the hospitals were closed. So those were the kind of disruptions and the interruptions the patients were facing, which was leading to definitely therapy interruptions. Uh, Infection rate among HCPs is on the rise, and we around a week back we were discussing with some of the oncologists only in one of the meetings, and they were sharing that some of their colleagues, they got COVID and they recovered, and they felt that they have developed immunity, so they went full throttle and started seeing the patients again. They got another relapse of COVID, so that is also happening. So with that, we'd like to take a small shot stop over here, and just like to bring in the point that we all at Biocon, we value your efforts. You are the front runners who are really fighting it out day in and day out and keeping all of us safe. So we show our solidarity towards you for the fearless work which you are putting in. So thank you very much for that. So that is one thing which we wanted to communicate to you. Apart from that, if we look at the cancer patients, they faced problems like surgeries were delayed, radiation therapies were interrupted, and more importantly, patients are scared. They are scared because with cancer, they are at a higher risk of developing COVID. And some of the studies have proven that the fatality rate is high if a cancer patient gets COVID. So that is the reason they're pretty scared. Also, WHO also reported one report which said that the fatality rate was 7.6% versus 3.8%. 7.6 in cancer patients having COVID versus all the other patients of COVID. So that is the kind of difference in fatality. So the patient's fear and the HCP's fears are right in terms of if we look at this data. Having said that, despite all the challenges what COVID brought in, hospitals were very quick to respond to it. It was, though there was no past learning or experience about this kind of a pandemic, but still people really put in their heads together and they were very quick on their feet. Some of the things which came in was robos used at the gate for screening in some of the hospitals. Some hospitals said that we will do COVID testing for all patients who enter our premises. We will not allow without that. Some hospitals came out with guidelines like no overcrowding at the hospital. When it is a caretaker who's coming along with the patient, then it is only one caretaker will be allowed, not more than that. The Max Hospital, for example, brought in a patient support app, which was an e-connect with the patients to help them during this pandemic. And Tata Medical Center also came with its own guidelines of what has to be done and how to restrict that COVID doesn't spread to other departments and other places in their hospital. So this is and many more. These are just few examples. There are plenty of more examples. I'm sure you are aware of that, which the hospitals and the HCPs are adopting to tackle and attack COVID. Okay, so this was an interesting study which was published by McKinsey. So they pulled out data from 2 physician sentiment surveys which was conducted on April 4th and 5th in 10 countries including US. So totally around there were almost like 2,000 HCPs who were interviewed, and 2 important things came out from this. This was basically, the question was what the physicians expect in terms of the digital tools adoption as well as the new tools. So 50% of the surveyed physicians, they expected that telemedicine will become more important in the future, and it will remain there and it will stay. Also 50% of the US based physicians, they said that probably e-tools to measure and monitor the vitals of the patients remotely will be used for clinical decision making, and the acceptance will increase. So these are the two important points which came out. Also, in the same survey, in this particular question, there were this was from the US, so there were 213 people who responded to it, and they said that uh, there was a 45% decline in the weekly patient consultations versus the pre-crisis level, even accounting even after accounting the remote consultations, the telemedicines. So even with telemedicines, they were down by 45% in terms of the consultations. So it still, what it meant to say was the remote consultations did not offset the loss of in-person interactions. I am sure this might be the case. So this survey was done in the month of April, so things might have changed a little bit. And However, what we realized was that yes, telemedicine adoption has improved significantly, and a lot of clinicians and patients are using it for day-to-day consultations with doctors. So, what does this mean for the patients? Are there any new realities which are coming out? Any new learnings which are coming out? So, there was an interesting publication, which is a review article. This was from a group of multidisciplinary set of doctors from a multidisciplinary team in oncology, from primarily from Europe, and what they found out were four important things which they said these are the new learnings which they witnessed, and they have noted it in this article. So one of it was that psychological impact of COVID on patients. So important thing which came out was because of COVID, there is an underlying fear, and the patients it is creating a psychological impact on the patients, whether it is because of the quarantining or whether it is because of the social isolation. But patients definitely are fearing this because of the higher risk of mortality. And also, it is also shown that the psychological impact will have a negative impact on the outcomes as well. The other thing which came was the altering treatments and guidelines. So, like the hospitals were quick in terms of bringing the logistic and the administrative changes in terms of managing the patients, the societies and the institutes and the group of doctors and HCPs, they were quick enough to come out with guidelines on cancer amidst this pandemic. And you would agree with me that on a daily basis, from the time if we look at from the lockdown, I recall it from around 18th March ke baad, almost within a week there were guidelines which were coming from one society or the other, and on a daily basis there were a lot of things which were getting churned out. People were pooling in to collate their data and their experiences and putting down as publications and sharing it with the entire medical fraternity. Uh, Other thing which also this paper talks about was strategies such as reducing the number of clinical visits, shortening of radiotherapy fractionation, converting intravenous to oral systemic and metronomic therapies, or even reducing the frequency of selected maintenance treatments that has been implemented in majority of the oncology clinics. And I'm sure this might be the case with your own practice as well. The third point which this paper highlights is addressing patients' need, that patients during this phase, they definitely do need additional support. Whether it is about more showing them more compassion, but probably it means that they need more hand holding. They may need more psychological support probably. And also they should be encouraged to explore creative ways to cope up with stress, including physical activity or a balanced diet and mindful based strategies to avoid, and also importantly avoiding overload information from the social media. So that's also very, very important point. And lastly, this also talks about that virtual community and patient support groups, they can be an excellent source of encouragement and support, both for oncology patients as well as their caregivers. So the last thing which this paper talks about is the importance of communication, importance of remote care and e-health during this pandemic. So this paper touches on the importance of telemedicine, and it definitely says that telemedicine has given a positive experience to both HCPs as well as the patients. And it definitely has proven to increase access to care. And it also talks about that telemedicine is also very much important and used for oncopsychologists, oncopsychiatrists to guarantee psychological support to individual patients while limiting their visits to the hospitals. And lastly, there's an important point which this paper talks about is that like never before, this is the time when hospitals should come out with updating their websites on a very regular basis. There should be some FAQs which should be already there published on the website. So whenever a COVID patient, a cancer patient, or a cancer patient is going to the website of the hospital, they get whatever FAQs they might be thinking of, they get answers to that. They may get answers to the updated information that is radiation therapy on in this hospital, is my major as well as the minor surgeries on in the hospital. So those kind of informations, it will be helpful for these patients. So these were the few of the learnings which all the publications spoke about. I'm sure that there are many more which we might not have covered in these slides, but in your own experience, you would have noticed a lot of other changes which might have come up because of the pandemic. So with that, this brings us to the section of our first discussions basis, whatever has happened because of COVID in cancer care. So, uh, so let me ask Dr. Julka on this question to begin with, that do you agree that digital tools for consultation is a viable way in today's circumstances? Telemedicine or
Yes,
video consultations here to stay. So, Dr. Julka?
actually, yes. Uh, Good evening, everybody. I think what you have told about all the points, we completely agree with that. And the digital tools for consultation is a viable way today in today's circumstances. And we have seen that virtual consultations and teleconsultations, like even video consultations and
Mhm.
audio consultations have played a vital role in this. Now, video consultations which are being done, people are still, I'm talking about Delhi, where some of the people at higher strata of society who are ready to have video consultations, who are ready to have audio consultations, these teleconsultations,
Mhm.
virtual consultations. But
Okay.
there are there are some people, in the middle strata or in the lower strata who are
Mhm.
not. Hello.
Yes, sir.
uh,
Yes, sir.
in the
We can hear.
in the middle or lower strata who are not tuned to digital consultations, virtual consultations. They want to see you physically. And
Okay.
once they want to meet you physically, they say half of our problems are solved. So they want to talk to you in not virtually, but physically. And I've seen that most of the patients, they are from the lower and middle socioeconomic strata. So
Mhm.
these things also we tell them that nowadays, since pandemic is there, So you should try to avoid the physical consultations, try to do video consultations, try to do audio consultations, digital.
Okay.
So I think your question of digital tools have to stay, for long. Slowly, people will get accustomed to it, and I think they will remain, for long time to
Okay.
come.
Okay, great. So I think that's very insightful what you said, that most people are adopting it, but there are few people who still want that
Still
physical
want,
contact. And
yes.
I think that's a very, very important point which you raised. So I'll ask the same question now to Dr. Ratnam to get a perspective from a non-metro city. He is from Madurai. So Dr. Ratnam, if you could unmute yourself and if you would
Yeah,
like give your views on this question.
yeah. Thank you, Dr. Arun. See, the point is, we are a tertiary care center,
Yes, sir.
and we are catering to about about 350 kilometers around our city. And see, the point about telemedicine is well taken. The patients who are on follow-up, or
Mhm.
patients for some mild symptoms post therapy, they are comfortable to connect with this on telemedicine, which we've been routinely doing. We were doing it earlier also, but it became more active after this pandemic. But the problem which we face, especially in a tier 2 city, when most
Yes.
of the smaller cancer centers had actually closed up and
Mhm.
new patients weren't accepted. And then we had a significant number of patients who were stranded here who were getting treatment in bigger cities like Chennai.
Okay.
So
Okay.
what happened? We had to keep. So even till today, we have been, even ever since lockdown, we have been working all days of the week. Only thing is the posse staffed, and then we go in rotation,
Mhm.
and we've been attending to patients. So what
Okay.
happens is the new patients and the severely symptomatic, because we have a palliative service also. So the
Mhm.
symptomatic, severely symptomatic patients are to be attended
Mhm.
physically. But
Okay.
otherwise, I think telemedicine is really a boon. There is no doubt about it.
Okay, great, great, sir. Thank you for sharing that. That's pretty insightful, and you even talked about the difference in different type of treatments. About that palliative patients would need a different type of approach, probably. Do I understand it correctly?
Yes, yes.
Okay, great. So thank you, Dr. Ratnam. Uh, there's one more question which we wanted to check with you. One more point. Sorry. So this basically, I'd like to pose it to Dr. Patil, Dr. Poonam Patil. What are the key issues in consulting patients remotely? How can a teleconsultation experience be more satisfactory or almost as satisfactory for a cancer patient? Because you'd agree that like what Dr. Julka just mentioned, that there are few patients who still are not adopting it properly, or
Yes.
there might be a set of patients who may come for telemedicine, but are they're getting the same kind of satisfaction which they would on a one-to-one visit. So
It's not
there
actually a
are,
matter just for patient, it's a matter for doctors also. We are
that's
Absolutely.
true.
satisfied when we see the patient face to face.
So true, ma'am. So very true. I think that's a very important point.
Yeah. So I think there's a lot dependent on the age of the patient also.
Oh,
What we
is it?
Yeah, that younger patients, they are all right with teleconsultation or video consultation, but
Mhm.
elderly people, I feel, are more anxious. They feel, because they have not been exposed to technology as much earlier, I feel, and the more old they get, especially patients in their 70s, 80s, they feel that more security is there when they come and personally see the patient, the doctor, rather than the younger people. Younger
What?
people are more casual, and they are able um, to sort their problems and all on video consultation. It
Okay.
also depends on what point in timeline are we seeing these patients. If it is a first time video consultation or a first time consultation with us, then it becomes a little challenging because it's more time consuming to go through all the records, and we cannot see the patient, we cannot examine the patient. So that's
Okay.
the challenge when we see them for the first time. And second, if it is on regular follow-up, just a regular 3 monthly or a 6 monthly or a annual checkup also, that is okay. That I'm comfortable with, when they can do the test near their house, or even if it is not an emergency, it is only just regular follow-up with some mammogram or some ultrasound. It can be postponed by a few months also. That's not an issue. But
Okay.
problems are when there are emergencies, when the patient has seizures and they want to do video consult immediately to show us how the patient is having seizure.
Oh,
Now,
yeah.
these are some things that cannot be sorted out, and it is very difficult for the patient, because they have all along banked on the doctor, saying that this doctor is there to solve my problems. But
Yes.
such things occur, it is difficult. They don't have a place to take the patient because of lockdown. It is difficult for them to bring the patient to the hospital also.
Hmm, hmm,
These
hmm.
are the challenges in working with patients remotely. How to make it more satisfactory is difficult. Yes, we can do our best
Hmm.
in satisfying the patient, but as I told you, that these challenges will forever remain. These
Yeah.
practical challenges will be there.
No, I think whatever points you raised, they are very, very phenomenal. You spoke about uh, patients' age, how the younger patients are they're easy on it. They find it pretty easy to use it. You also mentioned that if it is the first time, it is a little difficult, which absolutely I think you're absolutely right over there. The last point which you touched on, that in cases of dire need or urgent situations when they approach you, I think there's too much of a pressure on the HCPs as well. So that's
Yes.
a very, very important point which you spoke about. So thank you, Dr. Patil, for your views. Uh, Dr. Sheikh, would you like to add anything further to what Dr. Patil mentioned about
Hi,
the
good evening, everybody. Am
learn?
I audible?
Yes, sir.
Yes. Yes.
Yes. So, I would very much agree with Dr. Patil, madam, the points that she has raised, and also
Mhm.
in the background, what Dr. Julka has said. I would say we cannot make it an absolutely satisfactory experience for our cancer patient, especially as she mentioned, the elderly ones who would be a little bit difficult to understand the thing. The clearest example that you can have is somebody like Amitabh Bachchan is a chronic patient, a COVID patient, though not a cancer patient, writing in his tweets that it is very difficult to come to terms to the fact that a nurse or a doctor is not making a physical contact with him while examining. They are trying to see him at a distance.
Hmm.
So this is one area which cannot be, of course, filled by virtual consultation. But having said that, this is the only way in today's circumstances that we can provide the best of our expertise to our patients. Of course, in emergencies, there is no other way than to reach the hospital.
True,
But
true.
what I would suggest is, in order to make it more satisfactory, especially for the geriatric patients,
Yes, sir.
some younger person in the house or somebody who has a know-how of the technicalities of the things he is dealing with
Mhm.
would help us make the experience more satisfactory.
Hmm.
And as we keep using these technologies, I think these issues will keep coming up, and
Yes, sir.
improvement in the software that we are using. Like now, we
Mhm.
are able to share the reports
Yes, sir.
online on Skype as well as before the consultation. So that makes the experience very much similar to a in physical attendance of the patient with the consultant. So we'll keep learning as things go forward, but it is definitely here to stay, and it has to become part and parcel of our daily practice.
Thank you, sir. Thank you. Those are very important points which you raised, that some younger person in the family can help the patients get habituated to this, as well as what you also said, that there will still, with whatever technology it is there, there will be a void which will remain, which cannot means as compared to the physical meeting and the physical touch of a consultant. So thank you for those wonderful points. So with that, I would like to ask Dr. Chatterjee. that is there any new need of psychological counseling for patients? And do you think a separate intervention by a psychologist is necessary, all the more after the pandemic? Because till
Good
now
evening.
for cancer, there was some psychological counseling which was required only from a cancer standpoint, but now post the pandemic, how is it changing? Yes, Dr. Chatterjee.
Yes, good evening, everybody. Am I audible?
Yes, sir. Very good evening. You are absolutely audible.
I just want to add a point in the previous discussion and the comment about
Yes, sir.
teleconsultations. I think most of it has been covered by our panelists, but I
Yes, sir.
feel one more important issue is like when a patient relative cannot also visit to the hospital because of the location of the patient. Suppose he stays little far off from the hospital where the cancer facility is there, and
Yes.
you know, with the mass transit system all closed, the trains and all, especially in big city. I'm working in Kolkata,
Yes, sir.
so that geographical location and address of the patient is also sometimes important, because we don't have too many cancer centers in our suburbs and rural areas. So
Yes, sir.
sometimes these patients used to flock in our hospital on a regular basis to show the reports. So those are the areas also which will be looked down, and teleconsultation can be of help.
Okay. Okay. Great,
So
sir.
that
I
is
think
one point I
that's an
felt.
important point.
Yeah,
That's
so
an
far as
yes.
the
Yes, sir.
psychological counseling part is concerned,
Yeah.
certainly the cancer patients has prime importance so far as counseling is concerned. But in this given unprecedented crisis, we all understand it is not only the patients but the doctors and the healthcare workers are also in dire need of counseling for so many areas and avenues. So certainly this platform needs to be raised up in a big way. I mean,
Mm-hmm.
we need to have more psychological counseling sessions and available for most of our patients as well as community at large. So I feel here lies the role of associations, the NGOs, the pharmaceutical industry like you people should come up in a more bigger way, where different links or websites can be available where patients can access with their problems in given situation, which may be different. At least for cancer patients it's very important. Today only I saw a patient. She was treated in 2016 for CA breast,
Okay.
and she's all cured. She comes on regular follow-up. Dr. Julka will remember, because this patient, Veena Saraf, is also your patient, Dr. Julka. Are you there?
Yes, yes. Yes, I know. Yes.
Dr. Julka, Veena Saraf is one of your patients who is a CA
Yeah.
breast post-op, and she is on regular follow-up with me. And it was
Yeah.
just today that I visited her. Her sir
Okay.
insisted me that she has to visit you once, though she was on keeping follow-up. I saw her in January 2020, so it was just 6 months. I just asked over telephone that is she comfortable, everything doing well. We can just avoid a clinical examination at this point of time. So her son insisted, no, she has to visit you once because she is having sleeplessness for quite some time. She is always apprehensive. She has a lot of queries. And the moment we sat for the discussion in the hospital office when they came, so after 3 or 4 minutes, I saw that puzzled signs which she was having when she entered in my office, that was little relaxed. And she herself quoted to me that how she is feeling relief. She was having an apprehension that COVID might catch up her because she is immunocompromised. She got all the information that the cancer patient is immunocompromised. There is a chance of catching an infection. So, what are the do's and don'ts which I can help her in presence, live? She doesn't want to hear over telephone. So, ultimately, 3 or 4 days of discussion, she finally came today. And I had to just pat her back and say, nothing to worry, you're doing absolutely fine. That's what she was. She's only taking zoledronic acid, if you remember, Dr. Julka, 6 monthly as a prophylactic because her bone mineral densitometry shows osteomyelitic changes. So these are the issues where psychology counseling has immense role to play. And I think we need more of platforms where we can offer these patients this counseling which works in an eminent way.
Thank you, Dr. Chatterjee. I think that was a very passionate this thing which you shared with us. It definitely comes from your experience, and you definitely looks like belief that there is a immense need of psychological counseling, all the more post the pandemic. So thank you for sharing that. I would also like the opinion of Dr. Bondade on the same question. Dr. Bondade, are you there?
Yeah, I totally agree with Dr. Chatterjee that the psychological counseling is a must. It's not only for the disease, but also for COVID as well, because both the things are going on together. And like he said, for follow-up also, and for the ongoing patients also, counseling, telling them that you'll be all right, don't worry. Things like simple things and simple words like this will make a difference. So I think counseling, and whether should we have a separate intervention psychologist? Well, uh, it will be ideal if it is possible, but everywhere it is not possible. I work in a tier 2 city, so I have a lot of limitations of not only having additional consultant or having additional facility available, but also for teleconsultation we have a lot of issues. The basic issue is, the concept of paying for a teleconsultation is a big hurdle. I mean, if we have not come and see you, how do you expect us to pay? Is something which is so for me. Teleconsultation, though it is legal and everybody is using it, for me it's less than 5%.
Okay, okay. Oh, that's a very, very different picture from most of the
Correct, correct.
places, or most of the places, I would say.
Yes.
So, but that's interesting actually to know that. So, thank you, Dr. Bandade. Those were important points which you raised. Uh, Also, I would like the opinion on that when it comes to the psychological trauma, because healthcare workers themselves, they are facing a lot of challenge. A lot of them are they're getting ill. They're working under in PPE kits, and there is always a constant threat of COVID. They are away from their families. Some places they're working for 14 days, and then 14 days they are quarantined. So there is a lot of challenge which they also are facing, and I'm sure it is taking a toll on the psychological part of it, on them as well, psychologically as well on them. So how would they tackle their psychological trauma? So this I would maybe I'll ask Dr. Julka to respond to this.
Yes, actually, they have to understand that this is a part of their duty as a medical doctor to tackle the COVID situation also.
Yeah.
COVID-19 situation, has come suddenly, and nobody could imagine that this situation would come in their lifetime. So such a situation has to be dealt with by medical personnel, and that too, like in names, we have made a separate ward, COVID ward, so that only COVID patients are there, and there are junior residents, senior residents, and consultants who are looking after, and they do the duty in shifts. And because it is very hard for one person to do 24-hour duty, it's really stressing on the doctor. So that is why they are shifting duties, and all the consultants and the junior doctors are taking shifts in their respective areas and then taking care of patients. So patients are also happy. Their psychological counseling is being done, and they are being treated adequately.
Okay, okay, great, sir. Thank you for your views. Thank you very much, sir. Dr. Batna, would you
Yeah.
like to speak about that, how healthcare workers would tackle their own psychological trauma?
Yeah, there is a equal psychological trauma to the healthcare professionals also, because on one side they are rendering their services in such a difficult time, and on the other hand there is always a fear that in the exchange of giving your selfless services to these patients, I may not contract this disease somehow, because if I contract this disease, how I will serve the other patients who will come in next few days. So not
Wow.
only you want to be safe from this infection, but also for the sake of your family, where you are going back every evening, so that because of you, nobody else should suffer. So that is a very, I think, big psychological trauma, that because of me, no other person should suffer, may it be patient, may it be your family members or any other person. So it's a trauma, psychological.
I think that's a very important point which you said. There's a lot of moral responsibility, pressure
Yes.
also on the HCPs, as well as pressure that if they contact, their families will also suffer. So I think those are two very
Uh,
important things. Thanks for
Actually, one thing I
yes,
would like to point out.
yes, sir,
Hello.
please.
Ah,
Yes, sir,
uh,
please.
we have, our counselor. She
Yeah.
has designed the performa for quantifying the, psychological trauma to the medical staff, healthcare
Wow,
staff.
that is amazing.
So
That's
we are doing a study on this, and we shall be publishing it very soon. It is in the Max group of hospitals, Pan Max, all over Delhi, and in Chandigarh, and in other places all over India. So this study would tell us what is the trauma to the healthcare professional and how they are dealing with it, and how our counselor is helping them online consultations of psychological consultations.
So in
I
our
think
hospital also we have a dedicated psychologist, and she is also doing a survey on the perception of the patient of this pandemic. So
okay.
we are also doing it on a very large scale, and will be also in a process to eventually publish it.
Okay.
May I add a few points from my perception, what I see?
Yes, yes, Dr. Patil, please.
Yeah. So one is when we are seeing the patients physically, that time we are a little hesitant. We are not doing, at least I can tell for me that whatever detailed examination I used to do earlier before the pandemic started, I am still, despite all the PPE and whatever I am wearing, I am still not able to do the correct examination, physical examination, what we used to do earlier. Examining the patient with a stethoscope. With our gloves, we cannot palpate the sense what we used to get without gloves and palpating a patient's abdomen or patient's lump. Those things are missing. And when we are doing video consultation, we actually tend to give more time because they feel guilty that the patient is so sad, patient is sitting at a distance and patient is worried, and we are consulting the patient from a distance. Video consultation, patient has paid consultation fees, so we should probably offer a little more time and trying to satisfy the patient. So both ways we are not very satisfied, when the patient is physically coming, that time also, when the patient is doing video consultation at that time also. And sometimes the patients themselves play a mischief. They know that if there is a lump which is recurring, we should report to the doctor. But what they will tell, oh, because of COVID problem, we didn't come. So that is sometimes it hurts us that, okay, we are coming to the hospital every day for you people. And then when you know that there is a lump which is very likely a sign of recurrence or some issue, you should report to the hospital. So that time also we feel guilty that, see, because of this COVID and because I told the patient that, okay, come to the hospital only in case of emergency. Had the patient come in the regular time period, we would have not missed this finding. So these are the stress that we also undergo so many times, even though we are doing whatever we can, but they can't be quantified. These stress cannot be quantified, I think.
No, no, no. You are so very right, and thanks for bringing it out. Hats off to all of you, and a lot of power to all of you, I would say. So seriously, the more I interact, the more we feel that how much tremendous pressure you people are under. Yes, Dr. Chatterjee, you wanted to add something.
Yeah, I just thought the question which was posed by you is how do healthcare workers tackle their own psychological trauma?
Yes.
I understand being professionals and medicals, we are little megalomaniacs, and clinicians, we are not ready to share our bit of depression in a public or open space. We always try to hide and we cover it up that we are doing well. Well, that is not the situation. So I think we have not yet got any answer from the panelists to the question posed by you, and it needs to be addressed certainly. So I can just add my small thing. What we do in our setup, that is Apollo Hospital, is we have got a group. That's a WhatsApp group. I don't know how much it is helpful, but at the end of the day, or maybe over the 24 hours, whenever he or she is free, most of the time we are not very busy nowadays. So anybody who has these creative talents, he or she, maybe it's just playing a music or an instrument, or maybe some kind of uh, vocabulary skills or whatever it is, we are posting those videos in our group and all, sharing it, and then each of us are patting the other people's back, and whatever, it gives a little bit of satisfaction, or maybe that gives you a little bit of elation. So that's the small thing we are doing, and I
Great,
would
sir.
be
I think
more
that's
happy to
an
listen to
innovative
anybody
approach.
else.
I
Yeah,
said
that's
that's an
something very
innovative
different.
approach. Good. I think so. With on the same lines, we were thinking that is there a need, and this is an open question to all. Anyone can contribute on this. That in the absence of physical meeting and conferences and informal gatherings, should there be a platform only for healthcare workers of oncology who come there, join it, and they interact with each other, whether they want to discuss the new guidelines, whether they want to discuss how to ease out the pressure, the moral pressure or the psychological pressure on HCPs themselves, the way something like what Dr. Chatterjee was saying. So should there be a platform like this where people would like to join in, and if there was a platform available, if we take that initiative, would you all be willing and interested to join that kind of a platform?
Yes, I think there should be a platform like this. And this is a very good idea where people can discuss informally. People are doing webinars on various, people are
Correct.
speaking, one person from US, one from Australia, and one from, on suppose breast cancer. It was being done yesterday on heart, on head and neck cancers, on different types of cancers. But we feel that informal meetings like this should also be done so that people can share their thoughts and can get some insight into the various problems they are facing.
Thank you. Thank you so much, sir. Thanks. That was encouraging. So we've covered the first discussion point, and a lot of things which came out. I'll just summarize and I mentioned few, but there are more which came out. Telemedicine is here to stay. Psychological counseling is very much important, and it is also psychological counseling and evaluation for HCPs themselves is important. And there should be a source and a way to vent out the trauma which they undergo as well, to minimize the guilt feeling and to become positive. So that is also one thing. And there should be ways to minimize the moral pressure also on the healthcare workers. And probably if a forum is created, doctors and HCP workers all would like to join in and do informal discussions, as well as if there are certain case studies also, if you want to discuss, maybe it could suffice for both the things in one. So thank you very much for these important points which you all brought into the table. Really very appreciative of it. With that, I'd just walk us through the patient journey, how it is with COVID for the cancer patient, how it is changed, or is there any new learnings which are coming. So there were a lot of reports which came in that the time the lockdown happened, it created a lot of chaos as well as challenge for cancer patients. There was a news which was highlighted that there were certain patients who were getting treated in Tata Memorial Hospital, Mumbai, from Assam, and they were denied treatment because of the COVID outbreak. Tata, for temporary, this thing had stopped its services for a lot of patients. So these patients were under tremendous pressure and risk that their chemotherapies would be stopped. What will happen to them? and the disease will progress fast. They were staying at Assam Bhavan. They took the help of government, and when a flight couldn't be arranged because there were 4 patients among this group who came out positive, then government helped them and arranged a bus. They took almost a 2,700-kilometer journey to go back to Assam and get treatment and be Barua, which is also a branch of Tata. So that is the kind of the strenuous journey these group of patients took, and there are several and more examples of similar kind where patients definitely suffered all of a sudden when the lockdown came up. So this definitely brought in a new challenge for a lot of cancer patients. Their treatment was disturbed and disrupted. Uh, and there is a lot of news of different types from across the country, which is on the same lines which I was just speaking about. Uh, so we tried to look at that. How does it change the patient journey of a cancer patient after COVID? So if we look at each touch point, each origination point, whether it is from the symptoms to the screening and diagnosis, maybe because of COVID, there is some challenge which might be there in terms of screening and diagnosis, and there would be patients who might be coming to you at advanced stages now. They are scared. Earlier, they could reach the primary physician fast, but maybe because of COVID, they are scared to step out. They are ignoring it, and they are turning up in advanced distance. The referral network also would have got disturbed. The travel has become a new problem, which earlier was not there. But with COVID, finding out a safe traveling from a different city to some other city, it becomes a problem. Crossing a state becomes a problem. Even the local travel within the city, getting a sanitized cab becomes a problem. So all those are the new challenges which has come up. Even hospital identification, that some of the patients, they were getting treatment in some of the hospitals, but now they want to shift to a place which is closer to their homes, or they cannot travel to a distant city. They need a place which is closer to them. So that has become a problem. Some of the cases, what happened was some of the hospitals became temporarily closed. So patients have to then look for other alternatives. So that hospital identification became a challenge. COVID testing before getting inside the hospital, in some of the hospitals, this was made mandatory. So that is also one more new challenge which has come out for the patients. Then treatment regimes there were disruptions, or there are currently also disruptions in terms of radiotherapy is not happening or minor surgery is not happening. In most of the guidelines said that palliative care may delay it. Don't come to the hospital very often. Shifting from the infused chemotherapies to metronomic therapies. So those are the kind of challenges which even in the treatment regime this COVID brought in. Then for weekly treatment cycles, how will they stay? Where will they stay? Will they get a sanitized place to stay? All that. These are the kind of new problems which the patients are facing. And lastly, traveling back to home. This also became a challenge. So because of COVID. So with this patient journey in mind, quickly I'd like to just understand that how can cancer care sector increase screening and diagnosis rate in the face of social distancing? Because we interacted with a lot of clinicians, and they told us that definitely the screening is getting delayed, definitely diagnosis is getting delayed. So patients may turn up in advanced stages. So may I ask Dr. Poonam Patil, if you can, ma'am, would you like to touch on this and share with us your thoughts on this?
See, screening as it is only for breast cancers and cervix cancers in women, and in
True.
men it is again only for probably prostate cancer. So yeah, so regular screening as it is during COVID times has been told that it is only the high risk group which we have identified, they do require regular screening practices with even MRI breast or mammogram or coming to the hospital. But women who are in a standard risk group, the COVID times guidelines which came up initially have said that probably we don't have to chase them as such, and we should explain to them the importance of probably breast self-examination rather than they going to the hospital physically for a mammogram, because if we do a mammogram in case that lady is COVID positive, who turns out to be COVID positive, or she tells later that I was COVID positive, it is a big hassle for the radiography people. They have to sanitize the whole place. They have to keep the AC running on for 3 or 4 cycles. So a lot of time is wasted. So I think something for a standard risk individual, probably we will have to make do with only self-examination rather than visiting the hospital. So that's what I feel.
But do you think this will lead to, in a lot of cases, patients will turn up in advanced stages?
Yes, possibly yes. Possibly yes. But if I look at it from the other way, the value of screening mammogram, value of doing a screening PSA test, all has been questioned in the US. Though, of course, I would agree that those same things do not apply in India. But if I have to justify myself, I do have something to hide back on.
Okay. So, So, and does it also impact the diagnosis? So, what we thought when we discussed with few clinicians was that since a patient, imagining a patient who's getting some kind of noticing, let's talk about a breast cancer suspicion. So a lady notices some
that they have to come. So that knowledge should be there, that okay, if I find a symptom or if I have a lump or something, that they should come. So screening is, you're screening asymptomatic individuals for a disease. So that is different. Diagnosis is they are coming to you with a symptom.
Yes, with a symptom.
That's what I was telling you, that patients sometimes, despite knowing all these things, they do say that because of COVID scare, I didn't come. Though that malignancy scare is much more than COVID scare.
Okay. So thank you. I think that's a very important points which you raised. So Dr. Ratnam, would you like to add something on what Dr. Patil just mentioned?
See, we face a kind of dichotomous population. Kind of especially when it comes, I totally agree with Dr. Patil.
Yeah.
If the asymptomatic patient, I feel screening can be easily postponed because that is now not the most important thing that we should do. And I think enough awareness, if it is spread, is good enough. But of course, when it is a symptomatic patient, yes, it is very difficult to tell them to sit at home with a symptom and tell them to come back after the pandemic gets over. So we, as I told you already, we have been attending to our OP on a regular basis, even through the lockdown. And there are papers which clearly say that because of the effect of this pandemic, because of delay in treatment, delay in the schedules, delay in the type of protocols, defaulting of patients, this net effect of survival will definitely come down 5 to 8% across all cancer subtypes when you do the 5-year survival analysis, probably a little later compared to what was already best achieved. So this has come out of a few of the reviews that have been published by certain centers. Once again, I agree with Dr. Patil that if it is a screening which you are talking about, that could be very well, and especially in India, we are only going to be talking about breast mostly. Cervical screening has to be done in hospital at least in the outpatient. So breast can be easily tackled with a self-breast examination.
Thanks for sharing those important points. Thank you. So may I ask Dr. Sheikh, Dr. Imran Sheikh, that how can patients be made to feel more secure while coming to the hospitals? So are you currently, do you give them any advice? Because I'm sure you would be bombarded with these kind of questions that no, how can I come? Or if I come, what should I do? Because I'm really scared about COVID. So is there any advice which you give them? Is there a laundry list or a guidance document or something which you tell them? Or is it different for different patients? Dr. Sheikh, if you could, Dr. Imran Sheikh, if you could unmute yourself. You have to unmute yourself, please.
Sorry, can you hear me now?
Yes, yes.
So I would say when the lockdown initially happened, there was a lot of fear in the mind of the patient as well as the treating doctors. Over a period of time, as we have gone through this pandemic, and it's been almost now 3 to 4 months, fear on both sides has come down.
Yeah.
So we haven't prepared at our hospital or at our facility a list of or a pamphlet sort of or some patient brochure to prepare for the hospital visit. I would say most of them would be knowing about the social distancing, the hand hygiene, and other aspects of avoiding COVID infection, which apply to our hospital also. So nothing different from that. However, in terms of making treatment more comfortable for the patient and to reduce the level of fear, we have made certain changes in our chemotherapy day care. Like we have shifted from a huge facility which was housing around 30 patients in a single big hall to twin sharing rooms and maintaining proper social distancing, not allowing anybody other than one relative, and that too not with the patient. And of course, in symptomatic patients for daycare chemotherapy, I'm telling you, we do for the symptomatic patients, we do check, we do ask for a COVID report. And for those who are going to stay for 3-4 days at a stretch, it's mandatory for them to do a COVID test before getting admitted to the hospital. So that is the only thing which I see which is different from what we were doing previously. And as the patients, we have a patient support group, so they discuss among their fellow patients with similar diseases or different diseases about what are they going through, and the message is spread across the community. So that is one way where you can say we sort of prepare the patient for the hospital visit. The bottom line is to remove the fear from the mind of the patient that the place where you are going to go is a secure environment. Of course, there always remains a chance when you enter any hospital in today's day and age that you might catch the infection. But we have taken all necessary measures in terms of training of the support staff, psychological counseling, making chemotherapy administration more safer and things like that. So I would say this is what our hospital has done, and we are very strict with the guidelines which our hospital has formulated as far as the accompanying patients, accompanying relatives or attendants with the patients are considered. So I think that has gone down well, and slowly patients are settling in that mode.
Okay, great. Thank you. I think that's quite insightful what you just shared. On the second part of the question, I'd invite Dr. Bondade, if you could comment that is there any role which you think we could play, which can help, means in partnership with you, which can help in influencing the patients, that their fear, that the genuine fear of these patients reduced, at the same time not increasing any type of risk for them, with necessary precautions. So, Dr. Bondade, would you like to take this?
So as Imran has correctly said, that the fear has definitely come down as compared to what it was in the month of April and May. We have seen more people recovering. That's been in the media. So people, even the patients, have started knowing that that this is a disease where not everybody is going to die. So that fear has definitely come down. What we can do in addition to that to reduce the fear is difficult to say, but what we are doing is in our outpatient department, we take only 4 to 5 patients every hour. So, from, for example, 11 to 12, only 4 patients are given appointment, and then 12 to 1, the other 4 only. So that, they don't rush at one time. You space them in the OPD, so that, they are comfortable. Other
Great. I
than
think
that,
that
I
that's
think
an important point. Spacing, which you mentioned, I think that's pretty important and this thing. I particularly wanted to check with you: is there anything which you think we can do uh, as an organization, partner with you and help in spreading some
I
message?
think
I think you have already got a drug which is useful. So
Okay.
I think I would like to add here.
Yes, sir. Please.
I would like to add that we have a daycare center which is
Mhm.
about 5 kilometers away from the main hospital.
Okay.
And there is no COVID. It is a 15 bedded means including the recliners, including the beds, and it is a separate daycare center, free
Okay.
of COVID. I can say up till now, for the last 4 years it is running. It is a relatively new daycare center where we do about 15 to 20 chemos per day, and we do all the routine procedures. We do ultrasound, and we do small procedures like biopsies. So all these we tell them, and nobody is allowed, not more than one attendant is allowed there. And at the ground floor, they tell everybody is checked for his temperature and everything. And then they are allowed to go up to the second floor to the daycare center. And then it is absolutely, spacing is there, social distancing is there, absolutely safe and non-COVID. And we go with our masks and PPEs and all those things and treat patients, take the rounds, talk to the patients, and the patients are also wearing masks. So all these things, where we are already doing it, but I think you people can help us in, furthering the safety procedures.
Okay. Okay. Fair point, sir. Thank you.
Yeah,
Thank you. Yes. Thank you, Dr. Julka, for that. I heard
yeah,
Dr. Patil wants to say something.
yes.
Yes. Yes.
Yeah, I think you people, the media plays a very big and a very vital role here. And it should be coming in media also, whether it is a radio or whether it is television, to tell patients, to educate patients actually. Or for not just patients, anybody who needs to go to a hospital, to tell them that hospital is a place for sick people. So you go to the hospital only if it's absolutely necessary. You take your one close attender with you, go with all these precautions, do not go with somebody who has fever, and all those things I think actually should come through the media to educate the general public, because
Fair point.
patients are one of those public only.
Yeah. I think that
Actually, this is also very important. I agree with Dr. Patil that media plays an important role. And
yeah.
if you have heard ABP News, one of the news channels, they have called doctors. They call doctors from 2 p.m. to 3 p.m. every day to answer the questions about COVID only. And I tell them that you answer the questions about, people are asking questions from it is a live program, and they are
Okay.
asking questions, and they should have a program on COVID and cancer also.
Wow.
And
That's
I have
interesting.
addressed through a webinar to the cancer survivors, a, a webinar on COVID and cancer. So I have
Okay.
told them everything. So they are fearless now to
Wow.
come for follow-up,
Great.
or they can do on telemedicine. And
That's
I must tell you one thing. As a
yes.
dean of AIMS, I started telemedicine in AIMS about 10 years back
Oh.
and got it inaugurated from the then health ministerial.
Okay. So So you were futuristic even a decade back.
Yes, 10 years back.
Great, sir. So thank you. That's all the points which you raised are very important. And thank you, Dr. Patil, for bringing that media point as well. Very important. Dr. Chatterjee wanted to add something quickly. Yes, sir.
Yeah, I noted very nicely by Dr. Patil and Dr. Julka saying media plays an immense role. And as you know, celebrities endorse these issues. Some of them are definitely doing it, but we want it in a more bigger and larger scale since we have got audience TRP, which is very high at the moment. So in a way, my hospital, we have got a link. So we are doing a teleconsultation with our patients. We send a link to these patients how our hospitals operate. Like we have got a COVID facility, but it is in a different building. So to educate the patients and fear, just to alleviate the fear, we tell them that this is not a COVID hospital. The COVID dedicated part is another center. So when you are
Yeah,
coming to cancer center in our hospital, you don't worry, you are not mixing with the COVID patients as such. So
yeah,
even in the patient waiting area, we project on the screen about the video, about the safety measures, what we take. So when radiotherapy patients are waiting in the area or maybe in the OPD with safe distancing, there is a gap in between the two seats like what we are being advised in the waiting area.
yes, sir.
So those are the norms we follow and then we advise accordingly. It gives a little bit of confidence to the patients and family members.
Yeah, yeah, yeah. I think that's a pretty interesting idea which your hospital is following, and I'm sure it will ease a lot of stress on the patients, and it will give them a positive outlook towards treatment and coming to the hospital. I think that's very important. Can I on the same? Can you be with me for a minute? And I just wanted to check with you also, Dr. Chatterjee. Are you seeing a gradual increase in patient footfalls, new patients as well as the existing patients? So if you could break it up and tell us that what percentage of increase are you seeing from the lockdown period till now? Is it normalized to the pre-COVID era, or at what percentage is it?
At the moment, we are seeing 30 to 50% of the patients overall strength in the oncology building. But
Okay,
I would say it is again reduced. It increased from the month of May and June. But
okay,
as of July, there is a surge in Bengal so far as the number of COVID patient diagnosis is concerned.
okay,
So
okay,
there's an increasing surge. What Delhi has flattened in last 1 week. So there is a
okay,
big surge going on. So there is a big fear psychosis in the community at large. So for
yeah,
that reason, again, there is a dip in the number of patients visiting the hospital. So I
okay.
would say it is between 30 to 50%.
Okay, fair, sir. Thank you so much for sharing that. Dr. Ratnam, how is it in your institute at Madurai?
Regarding the pattern of COVID, is it?
The pattern of cancer patients' footfalls, sir. Is it improving now, or is it
Oh, okay. You
still
mean the general footfall, or you mean COVID affection
no?
in the patients? No, you mean the general footfall.
Footfall of your cancer patients, sir.
No, general footfall definitely has come down because we don't have public transport. And see, I work in it's a trust hospital.
Mm-hmm.
We see about maybe about 1,200, outpatients in a month.
Okay.
So
Mm-hmm.
now they just like come down quite significantly. However, those who are on adjuvant chemotherapy,
Mm-hmm.
the leuks and lymphomas, those patients are all getting their e-passes and then they are able to come for treatment. The
Okay.
palliative, we have changed to oral chemotherapy with after some counseling, and they are trying to take it at home with video consultation.
Okay.
So overall, the footfall definitely has come down drastically. I mean, we have uh, maybe about 60% load in the outpatient, maybe 50 to 60% of the original numbers.
Okay. Okay. Thanks for sharing that, and we hope that things improve. In some, it is in some places improves. In some places, it is as the cases increase, it comes down. So that's the disparity which we are also noticing. So thank you for sharing that.
I
I
would
would
Doc-
like
just,
to,
yes, sir.
hello,
yeah,
I would
yes, sir.
like to share one thing
Yes,
that in
yes,
our daycare center, there
yes.
has been not even 1% drop in the
Okay,
footfall, right
okay,
from the COVID area, COVID time to now. It
okay,
is same and absolutely same. And the center is full, and our bosses, they administrative bosses, they said this is the only center which is running for max, and which has been running throughout.
Okay, let's
So,
keep our fingers crossed.
yes, yes.
Fortunate that's good actually. So thank
Yes.
you.
I
That's
would like to know. Hello.
yes, sir.
Yeah, I would like to know that the doctors from other different areas to share their views about the footfall of patients in their respective centers.
Yeah, Dr. Sheikh, how is it in KD hospital?
So at our place, definitely it took a hit when the lockdown was announced, because we were catering to a population which was not only restricted to Mumbai but pan India, I would say. So that was really hit hard when the lockdown was announced. But over a period of time, I think it has gradually increased. The surgeons, quite a few of them were affected, quarantined, isolated, recovered. So a major chunk of our work comes from them. So as they have recovered and started operating again, we are again getting patients for giving chemotherapy, both adjuvant as well as neoadjuvant. I would say it went down to around 20-25% of the work initially when it
Yeah,
was announced and there was chaos all around.
yeah.
Gradually, it has picked up. I would
Okay.
say it is now not come back to normal, but around 50%.
Okay, fair point, sir. So thank you very much. I think with that, if you allow, I'd like to invite Dr. Neera to take us through the next session because there's a lot of agenda which is left. So thank you very much for the discussion points till now. Really, really very appreciative of all the insights which you shared. So I'll hand it to Dr. Neera to walk us through the next section.
Thank you
So.
so much, Arun, and very good evening to each one of you. What an engaging discussion so far. Thoroughly enjoyed. So I will move on to the next session, next part of this discussion, that how have treatment modalities changed from the pre-COVID to COVID, and now nearly towards the, we can say, the post-COVID era. We are expecting the things to go better. So next slide, Arun. Arun, could you please change the slide?
Yeah, sorry, it got stuck. Just 1 second.
Sure,
Okay,
sure,
yes.
sure.
Sorry,
Great.
sorry.
So
Yeah.
thank you so much. So various recommendations in cancer management amidst COVID have come. We have seen that for surgeons, the various guidelines and recommendations have said to delay the surgery unless and until it is really must, because of the aerosol exposure and the PPE unavailability and exposing the staff at risk. The neoadjuvant CT evaluation and the risk evaluation should be done carefully as per FHNO. In management of breast cancer, the age, as Patil madam had already said, that the age of the patient is very, very important. And if the patients have comorbidity, they should be discussed and then accordingly taken for the treatment. The history of the history has told us that how the crisis, they turn into opportunities. The intravesical BCG administration and the leucovorin unavailability, the crisis of leucovorin, that led to the change in the NCCN guidelines. So it's about the challenges come opportunities. In oropharynx, locally advanced cancer, the radical CRT with weekly cisplatin plus minus nimotuzumab in cisplatin fit patients is the recommendation. This is the latest paper from Tata Group of Hospitals. Amidst COVID, they have defined that what subsite specific guidance for head and neck cancer patients that should be recommended. The other recommendations from ESMO has done that they have stratified the patient population according to low risk, high risk, and the medium risk. And then accordingly, the treatment should be decided. The another recommendation, or the recommendation from Dr. Pramesh, who said that if the intent of treatment is curative, we all know that these patients should be prioritized and called on priority for the treatment rather than the patients who are on palliative intent. So next slide, Arun.
One second.
Yeah,
I'm
yeah,
changing. I'll have to stop sharing and then reshare. It's stuck.
Sure,
Okay.
sure. No issues. So meanwhile, when Arun is going to present till then, we have various guidelines in this era. Each and every national and international association has tried to give some recommendations for treatment of these patients, like ESCO, ESMO, Australian guidelines, and the paper which is very much from India, that is the Dr. Patil's paper, that how do we go about treating these patients amidst COVID. So these are the various recommendations which we see. If you could, thanks. The Society of Surgical Oncology, ESCO, ESMO, and the Australian Society, and Dr. Patil's paper, which is there. So they have given some recommendations that how do we treat and what we should prioritize and what are the treatment recommendations for these patients. Next, Arun. There is some issue with the
issue. Pardon me for this. I don't know.
No
why.
issues.
Something is stuck.
Do you want me to share, Arun?
Yeah, maybe. I don't know what's happening.
No, maybe then I
Okay,
can start the discussion, because that was the thing, that various guidelines, various news, press releases amidst this era, that what do we do for these cancer patients for treatment during this challenging times. So I would start, meanwhile, Satish, you can start displaying, but I would start the discussion till then. So my first question is for Dr. Julka, sir. Sir, we have seen so many guidelines and recommendations these times. Do you think that we need India-specific guidelines for the management of important cancers, which are basically the burden for our country, like head and neck cancer, breast cancer, and cervical cancer, the need of guidelines which is India specific? So question to Dr. Julka, sir.
Yes, actually, I've been saying right from the beginning that we should have India-specific guidelines for India-centric cancers. For example, breast cancer, commonest amongst females. Next comes cervical cancer. Then in males, we have lung cancer, head and neck cancer. So we should have India-specific guidelines rather than follow the Western guidelines, because some of the guidelines may not match or may not be applicable to Indian context. So that is the first and foremost thing, because as in charge of Delhi Cancer Registry earlier in AIMS, what I found that all these India-centric cancers, Indian specific guidelines are not being made. And then we had gone to ICMR to tell them that why don't you take the initiative and take people from various strata of society and then make the guidelines, and take people from all over India, the physicians, the medical oncologists, the radiation and the surgical oncologists, sit together, make the guidelines, and then India specific guidelines should be made.
Thank you so much, sir. That's really the need of hour, and thank you for your insights. And we look forward that some initiative sooner than later should start, and we should have our own guidelines for these most prevalent cancers. Dr. Bapna, would you want to say or add what Dr. Julka has said? Dr. Bapna? He's not
Yeah,
there.
I
Okay.
totally
Yes, sir.
agree. Yeah, I totally agree with what Dr. Julka has said, that some of the cancers which are more prevalent and are more common in India. So we have to make our own guideline rather than cut and copy paste from the Western world. So that can solve a lot of problem. Even not the guideline at the national level, but individual institutes also can also form their own guidelines. Like in our hospital, we all sat together and form the guideline, how we are going to manage. So we have been so very successful that since March, actually none of our patient contracted this viral infection, nor any healthcare professional also. So the kind of the guidelines we laid down, so we have been quite successful in our own way.
That's great, actually. So this was where I was coming for my next question, but thank you for throwing insights on this, because that means that Bhagwan Mahavir Institute, you have your own hospital
Yeah, yeah.
protocols, and that's really an inspiration, and I think that's the way forward as well. So, Dr. Sheikh, would you want to share something? That do you have similar institute-specific protocols or guidelines at your center, Dr. Sheikh? Dr. Imran Sheikh, sir. I think, am I audible, Satish?
Yes, you are.
Yeah, you're audible.
Okay. Okay. So, Dr.
Dr.
Chatterjee,
Sheikh,
meanwhile,
yeah.
Yes, Satish.
No, I can see. No, I can see Dr. Sheikh is unmuted, but maybe we are not able to hear him. So, Dr.
Hear
Chatterjee,
him.
please go ahead.
Yes, Dr. Chatterjee, would you want to add? Because you said that you have Apollo Hospital, some of the protocols and things. So,
See, we have to categorize the tumors like category 1 and category 2. You know, most of the tumors in the category 1, like the head and neck cancer, lung cancer, cervix cancer, they are to be prioritized towards the treatment. We have got an NHS protocol, even we have got a Tata Memorial Hospital protocol. So going by those protocols, Tata Memorial has done a protocol for patients treating with cervix, or rather head and neck, gynae and breast. So we have adopted a bit of those protocols in our institute also. Like what we do is a routine RT-PCR for all patients before starting radiotherapy. And that is only for once. And thereafter, usually patients continue treatment, and we don't do a repeat RT-PCR during the tenure of radiotherapy. And of course, we have cut short the number of fractions as much as possible. We didn't do for head and neck cancers, though there is some alternative recommendations for compressing the treatment duration. But so far, we have not done it on a routine basis by increasing the dose fraction to 2.5 gray or 2.25 gray. But yes, in palliative situation, we have started single fraction radiotherapy for 800 centigrade. That helps in reducing the patient load. And for medical oncology, as you know, daycare, we are doing one-time RT-PCR for patients who are on concurrent chemoradiotherapy. And usually patients continue unless he or she develops any symptoms. And for the 3-weekly chemo schedule, we usually alternately do a RT-PCR. That is also the guideline what we follow in our institute for the chemotherapy schedule. So these are some guidelines where we are taking extra care. Normally what we know in our situation, like some cancers which are more prone for COVID infections, they are the patients on immunomodulators, especially on bone marrow transplants, or patients with lung cancer who are on radiotherapy. So we have prioritized this group of patients who are taking extra care to avoid as much as possible. Now for radiotherapy, we do a sanitation method, like every patient who is being treated, and thereafter we sanitize the table, the couch, before the second patient is taken for treatment. And it is routinely the COVID team or the treatment delivery technicians, they have to use the PPE kit routinely for delivering radiotherapy who are on and we have taken care that we don't use all our manpower personnel for treatment in the machine. We have a reserve force because initially in the first March or April first week, we had a calamity of this COVID infection in our ward as well as in the radiotherapy. So we learned the process. Now we are going little slow. We are trying to divide the patients on two machines, and we have a reserve force also in case somebody gets into quarantine, which already happened. It's sets of health workers, healthcare workers, sisters, and paramedics in a bunch of 9 to 12 people getting quarantined at one go because of the sudden exposure and contact. So we learned it hard way. Now we are always keeping a reserve force and not utilizing it one go. So that is one way we are able to cope up with sudden unprecedented crisis what is happening. So these are the small things we have adopted so far.
Sure. Thank you,
Quite
sir, for
fortunate
sharing
enough
this.
that our triage team at Bhagwan Mahavir Cancer Hospital is, working so very efficiently, because if any of the institute has the triage team very efficient, then half of these problems can really be tackled at the initial time only. And from the mid-April, we all sat together, medical, surgical, and radiation oncologists, and we are offering the same treatment which we were offering in the pre-COVID era, because there was a report from NHS that if you compromise the treatment in the curative setting, then you are be ready to face the chances of recurrence and mortality.
True,
So
sir.
the benefit outweigh definite benefit of giving the full treatment outweigh the risk of dying from COVID.
Very true, sir. Thank you, sir. That's really very important. Dr. Ratnam, at your center, Meenakshi Mission Hospital, do you have specific protocols this times?
Yeah, definitely. As what others have mentioned, we are also following. And I would side with Dr. Papna. Most of the curative settings and like cancer, breast, and lymphoma and leukemia, with all the necessary precautions, we've been following the same protocols. There's not no much change. Where we really made a change is some of the time situations where we could avoid weekly schedules, we made it 3 weekly schedules. The immunotherapies, we made it, we've extended the schedules as per current guidelines. And of course, in the palliative setting, we made most of the therapy wherever there is, an approved indication, we made it oral therapy so that the patients can take it at local place, and then we give them the contact of the telemedicine. So we give them 2 or 3 cycles prescription, and then they are able to check the blood investigations and get back to us on telemedicine. But the adjuvant and the neoadjuvant setting, there has not been much change. So this is with respect to the protocols. And with respect to testing, there has been a lot of controversy, what test to do, when to do. Each institute has its own guidelines. So what we do is we are actually using the PPE and literally treating every patient like a COVID positive patient. And those who are getting daycare, we are just continuing like as we used to do earlier. We thoroughly screen them for COVID symptoms. If anybody has suspicious symptoms or they come from a containment zone or have a contact with a positive case of COVID, then we isolate that patient and have them tested. Otherwise, they get therapy as usual. And these lukes which get into the hospital, and who is this patient who's going to stay in the hospital for the next say for his induction or consolidation therapy, then anybody as a hospital policy, when they get in, they get tested for COVID before putting them into the non-COVID zone. So there is a pre-COVID and the non-COVID zone, so and COVID zone. So we triage and put them in. But I
Sure.
think guidelines wise actually not much change in the curable setting.
Sure, sir. Sure, sir. Thank you, sir. So the last question for this session, particularly this section, is that we have genetic tests like Oncotype DX, the MAMA print, EndoPredict test. So my question is to Dr. Bondade. Sir, how much you use these tests in routine clinical practice, and do they really have assistance in terms of making decisions or informed decisions for patients for choosing for chemotherapy? Dr. Bondade.
Theoretically, yes. Guideline wise, yes. Practically, no. So Oncotype DX, I have suggested few patients. None of them could really do it. Few of the patients have started doing the generic version of it, which gives us some idea about the requirement of chemotherapy versus the hormone therapy, just like Oncotype DX. And few people have accepted because of the cost factor, which is around 50,000 per test. So yes, it is important, and especially in this era where you can avoid chemotherapy, you can go for a OPD outpatient-based treatment. This would definitely help, but practically it is difficult to adapt.
Okay, okay. Thank you, sir. Dr. Patel, madam, what are your thoughts in terms of these genetic tests and the routine clinical practice?
As Dr. Shailesh said, I would also agree that theoretically, yes, but practically how many percentage, what percentage of patients actually go ahead and do it is a very small percent. Hardly 10% of the patients are actually able to do Oncotype DX or EndoPredict. As he said, the Indian version, CanAssist version also is used. But sometimes patients feel when they come to know that that is also not a sure shot thing. There is a disclaimer that comes below that this is not the 100% thing. Ultimately, you have to make your own balanced decision. So then they sometimes feel they ultimately it's on them to take that decision, whether to take chemo or not to take chemotherapy. So as he said, I would agree that practically, yes, it should be done, but practically it doesn't happen.
All right, all right. Thank you. Thank you so
I
much,
like
madam.
to
Yes.
I like to add one thing.
Yes,
Uh,
sir.
yes, I agree with the previous two speakers, Dr. Patel, also that theoretically, yes, we have been getting this Oncotype DX not since now, but for the last 10 to 15 years. When Oncotype DX was invented, first of all, we started with Oncotype DX in AIMS, and some of the patients could afford it. But here I find in Max and private sector, more patients are able to afford, but it is not beyond 10 to 20% who can afford Oncotype DX. So our decisions are solely based on clinical parameters, and we make our decisions on clinical parameters, especially when patient cannot afford. Theoretically, yes, we should do it, but I think we should have Indian version we already have, but we still feel insecure about the validity of the Indian version. That is
Sure,
the
sir.
only thing.
Sure, sir. And is it so that the utility is restricted to the early breast cancer and DCIS only, or?
Yes,
Okay.
early breast cancer. And
Okay.
ideally, it should be T1 and maximum up to T2.
Okay. Okay.
And N1, they have extended it.
Okay.
So that is another area, where we have to see.
Okay. Okay. Sure, sir. That's helpful. Thank you so much, sir. So with this, I would invite Satish Menon, Heart CSO for the oncology. Satish, over to you.
Thanks, Dr. Neera, and a very, very engaging discussion so far. Thanks a lot, doctors, for your active participation. We have about just another 35 to 40 minutes to go, and I assure you we'll try to keep it as interesting as it was till now. Our next point that we would like to talk about is the impact of this pandemic on the affordability of the drugs. We all know that cancer care by itself is rather expensive for quite a few cancer patients in India. And what the pandemic has done is that it has further worsened the situation. Last week, and there was an estimated 14 more Indians
Your
who had
voice is
lost their
trailing
jobs.
off. Your
Uh,
voice,
Having problem.
right
your
now,
voice.
Understanding.
is it
Yes.
okay?
Yeah. Yeah.
Yeah.
Maybe if you want to switch off,
My
you may do that if that helps. If you want to
Pardon?
switch off your video, maybe you may
Yeah,
get better.
I'll do that. I'll do that. Thanks, Arun. Yeah, so I'll just switch off my video just to save on some bandwidth. So yeah, so as of April last week, there were about 14 crore Indians who had lost their jobs. And we really don't know what's the figure right now. The CMI is yet to come out with the latest numbers. But I would imagine it would not have changed much, at least in the negative way. It would have only increased. So in this situation, what does a cancer patient do? So Arun, if you could go to the next slide. Uh, so on this, we would seek some, suggestions and some inputs from all of you here. First and foremost, we all know that patient assistance programs is a given in cancer care, right? So any and every drug that is being offered comes with its own patient assistance program, and so have we been offering patient assistance program. We suspect that going forward, there will be a pressure on most of these companies also to continue patient support, primarily because lower patient footfalls would mean lower sales, and lower sales means lower spends, and lower spends means lower patient assistance. So in this situation, how do we still keep patient care at the topmost as the topmost priority for the entire healthcare sector? So we were thinking, would there be a merit in providing a zero interest loan or low interest loan for patients under the patient care program, patient support program, to bear the cost of our products? So would that solve at least for the immediate cash outlay problems? So can I ask Dr. Sheikh to comment on this, please?
Yeah, so Dr. Satish, I would say in the wake of this pandemic, definitely patients are stressed. I'm seeing more and more of my patients who are not only using Biocon products, but other products which had patient assistance programs asking for more help from the parent company or the drug manufacturing company.
Yeah, yeah.
Especially because the sole breadwinner in the family has either lost the job or has got a salary cut. So it's becoming increasingly difficult for them to cope up with the increased expenses. So yes, definitely. In the short term, I would say some sort of patient assistance program, either in the form of what you have provided in the question itself as an example,
Yeah.
no interest loans or low interest rate loans would be one way to do it. There are other patient assistance programs where I would say the drug goes on for a long period of time, like or with biotherapy, radiation therapy like Biomap. I would want to see more assistance from the parent company in terms of giving more free cycles to the patient. I do understand the theory that the sales would not be as great in this era, but then I
Sonia
would
ji,
say that depends upon the treating physician,
हाँ
how
जी,
you
that's
counsel
fine,
your
thank you.
patients. So if you counsel the
Okay.
patients in the correct manner and patient agrees to using the drug, I think there should be some incentive given to the patient to continue therapy in this bad situation. So increasing the number of freebies that you provide would be one way. And of course, I've never had this experience of putting the patient on some no or low interest rate loans. But what we have already been doing and giving
Yeah.
2+1 or 3+1 schemes I would like that thing to be extended to
Okay.
more products and to more number of cycles. I think that would definitely go a long way in improving the compliance of the patient. And when the patients are going to be there, definitely the company won't feel the.
Yeah. So thanks a lot, Dr. Sheikh. I think you made some pertinent points there, saying that yes, in this time of the pandemic, the economic stress on the patient is far more, and of course that you seem interested in this no low interest rate loans, but however, you would like to see more of patient assistance being rolled out for cancer patients. Uh, can I ask Dr. Bondarde to also comment on this? Whether this idea of a no or low interest rate loan is would be appreciated by the patient, and would it really solve a problem for them?
The issue, I'll tackle both the issues. One is the low interest rate loans. You know, most of the time the costly medicines we are giving it in a palliative setting. So what happens if after 2 cycles patient the relative lose the patient?
Yeah,
You know,
yeah.
that
Okay,
becomes an issue. And second thing
okay.
is, it is better to give a patient support, because I'm not a businessman, but you can definitely make out that some business is better than no business. So if the patient assistant is increased, I think there will be more patients who will be
Yeah.
able to take the treatment. And I don't know whether you can take this under your corporate social responsibility of providing some free medications to the patient. So that would suffice by both way. You know, neki bhi karo, or that becomes a business point
Correct.
also.
Right, Dr. Bondarde. And yes, I must tell you that this was an idea that we are toying with. But as of now, we are trying to support as many patients as possible on who are on Biocon cancer patients, basis your recommendations. Can we have the next question on this? Yeah.
I think just 1 minute.
Yes, Dr. Julka. Yes, Dr. Julka.
I think I agree with the earlier speakers that patient assistance program should be made more viable, because they should be increased, patient assistance programs, rather than low interest loans, because patients are not interested in, low interest loans and all these. What they are interested, if you are giving 1+1 or 1+2, so they will be very happy to take all the medicines, Biocon products.
All right, all right. Thanks, Dr. Julka, and we really appreciate these inputs. The second point that we were looking at was.
Can I add something here?
Sure, sir. Sure.
So we have recently seen, example of a drug by Pfizer called palbociclib. So they have this EMI program. Suddenly, when we counsel the patient that you have to just pay 38,000 rupees per cycle, then most of the patient, it gives them a psychological impact, and 38,000 sounds very plausible and feasible for him. So rather than paying the full cost per cycle, so this has really worked for them. So that kind of model with zero interest rate plus a good EMI proposal can really work out, I'm telling you. So Biocon can also work on these steps. This has worked for Pfizer, and this costly drug palbociclib can now be affordable for good number of the patients. This I can tell you from my own experience that it has worked.
So thank you, Dr. Bapna. You're saying that something like a no interest loan would really be appreciated by the patient.
Good EMI proposal.
Yeah, and a good
EMI.
Yeah. So thanks, Dr. Bapna. The second idea to tackle the affordability problem was, should we have something called a tiered PAP, a tiered patient assistance program, which is that basis the income levels, basis the economic condition of the patient. If we can assure a good turnaround time, say within 24 hours, the patient gets to know under what slab he will fall, whether it's a 3+1 or a 4+1. Would that be a better alternative for the patient? So can I ask Dr. Chatterjee to comment on this?
Yeah, should be some incentive which works out positively. Now, this has been started, if you remember, about imatinib long time back, when the Gleevec was started, and that was based on the income of the patient. and it took a huge upturn. So this can be the newer and innovative options which can be thought about in implementation. Certainly, when we are using these expensive drugs and treatment like immunotherapy, or when we are using these targeted therapies. So I think this needs to be incorporated in a very professional way, and this can work out. So why not give a try? This is the right time to board the train so that we miss the bus. I mean, miss the bus in a way like patient also misses the opportunity and the outcome gets impaired. So this is the right time to throw these uh, magic issues to the patients, definitely.
Very
It's
well
worth
put,
trying.
sir. Thanks. Very well put, sir. So, right. So, I take it that you would rather you saying that let's try out this and see what how we benefit the patients on this. Dr. Ratnam, any comments on this? Dr. Ratnam? Okay, Dr. Patil?
Yeah, on a lighter note, the economic impact has not just been on the patients, but on the doctors as well. A lot of have taken a hit, especially where their income is footfall based.
True.
Maybe I have a little difference in opinion here.
Yes,
I would agree with Dr. Shailesh Bondarde, where he said that loans may not be the best thing. Increase your patient support program, and this at different income categories, we prioritize the patient's support. Here, I have seen both ways where poor patients for many drugs have not been able to get into the program, and rich people who can afford well the medicine has got into the program. Many times it is a third party oriented segregation, and somewhere something goes wrong. So I probably would look at blanket therapy support to all rather than prioritizing based on their income. Yes, but if we call you and tell you, see, this patient is really poor, can you help this patient a little more? And there you oblige us by helping the patient, not helping us. But I would appreciate that more probably.
Yeah, thanks, Dr. Patel, and I think that was a very frank opinion that you have given. So thanks a lot for that. Can we move to the next question, Arun?
Oh, 1 second. It's against 1 second.
Okay.
So
I think the question was more around will hospitals and will hospitals take this route of tiered charging to the patient basis income levels? So would that be a plausible option for hospitals going forward? I think that was, yeah. So would hospitals and doctors also consider moving to an income-based invoicing system where the wealthy pay a little more than the others? So, so Dr. Ratnam,
yeah, I would like to come in for that question because I see both sectors of patients. See, I think I'm not sure what the others would have to say. I'm sure Dr. Patil works in a structured institution. I also work in a structured institution. So I think we don't have the right answer to that question that you're asking, because we are not at the end of the day the hospital administrators to decide what each patient will pay depending on their tier level. But of course, the choice is here given to the patient. So we have the free section. We have being a trust hospital, we do have the section where we treat the government scheme patients where they don't pay any money. So there are approved regimens, and which are wherever we are possible to push those patients, we do it. And the richer patients, they opt themselves and then go into the other side of the hospital where they go, and that's the patient who is here receiving the immunotherapy and monoclonals and those kind of drugs. And then coming back to the support program, once again, I had my own views again on this particular aspect. I think the section where I practice, I think the extended support program would work better than trying to put them on an EMI and other things, because on the lighter note, we will start looking like insurance agents trying to sell some policy, which obviously as a doctor we don't want to sit and talk to them. And the true note is, whenever this becomes a little more business like, and I'm quite sure that initially when before the generics came in for trastuzumab, if I remember right, Roche had brought this kind of a program where an insurance would be taken and patient starts paying some money and then something like that, and it was not very well taken actually. And when I had a couple of discussions with our colleagues, I think Roche brought this about 10 years ago, and I think most of even our colleagues at Chennai and other bigger cities said that that was not so well relished. So if at all the company wants to honestly extend some support, and that's going to be during the crisis period, depending on the tier based or the flat based approach, you can give an extended support program for the patient. And I think that would be useful for people in our section of the community. And the charges for the patient depending on their tier, I think I may not have an answer because it's more of an administrative question.
Okay. Thanks, Dr. Ratnam. I think if I understand you well, you're saying give an extended PAP, maybe even a tiered PAP, but a loan is you feel is not probably would not be well relished by the patients. So thanks a lot for that. And so can we move to the next slide, Arun? Yeah. Now this is a point which I think we can discuss a little bit at length. We know that while 70% of our population resides in rural areas, about 95% of cancer facilities are in the urban India. Rural areas, the cancer incidence is less, but mortality rates are double. So, and this is primarily because rural areas, people have to flock to the urban centers for whatever support and treatment is that is available there. Given the fact that cancer care is becoming expensive and that most of the patients are out of pocket patients, rural patients are really finding it difficult to take cancer treatment on their own. Also, the cost of travel, the cost of settling out in an urban setup, all of that increases the burden of cost. And whatever, and if we actually look at it, and this is all basis of paper, all these points have been mentioned on a paper. And when I read through it, I was really surprised to see that some very obvious facts, like most of the societal help given by the NGOs, given by trusts, are all for the tertiary care centers or all for the urban centers. Even the health minister's fund, the Rajiv Gandhi Yojana, everything is aimed at the tertiary care centers. So there is very little actually happening at the rural. Next slide, Arun.
Yeah, I've changed it. Next slide.
Yeah.
This is the next slide.
Yeah, got it. So again, this is one aspect of it is the need for patients to travel, the more cost, more settling costs in urban areas. The other aspect is also the social areas. I mean, it's actually a culture shock to go out somewhere and adjust to a new place. We find outside Tata Memorial in Bombay, we actually find people staying under the Parel Bridge, Lower Parel Bridge in Bombay, waiting for their turn to get into TMH. So all of this, so it's actually a very big problem for the rural patients. It is in this background. Next slide. Arun, I'm not seeing the next slide. It is in this background. It is in this background that a group from Tata actually had a paper in the JCO, Journal of Clinical Oncology, in 2017, where they proposed a organization of chemotherapy and systemic therapy. The whole idea was that you set up a basic center at the district hospital level, a little higher center, a little higher facility at the medical college center, a little higher at regional cancer, and then the tertiary care. So it's a 4-tiered approach. And the whole thing, what this would help was the rural patient gets care more closer to home. Now, this would actually mean setting up a full-fledged infrastructure in these district setups, in these medical college hospitals, to cater to these patients. So on the background of this, if we can move to the next slide, Arun, it will be great if we can, yeah, not visible yet, Arun. Yeah. So before I go to the discussion points, one point is, of course, the setting up of rural and semi-rural, setups for cancer care. The other aspect, which is of course more common today in the pandemic era, is the home infusions. Now, this is a highly debatable topic. We know that we've had numerous discussions on this across the country, and we know that there is a definite, a definite, what do you say, an objection to chemotherapy at home, primarily because of patient concern only. But given the current situation, is it time now to at least look at home infusion as an alternative? If not for all patients, if we could categorize patients, if we could look at risk levels, define a group of patients, maybe using tools like predictive analysis, and say in this group of patients the risk of adverse events would be least. So can we look at least those patients where home based chemotherapy could be given? So there are 2 points that we will discuss when the discussion points come up. One is the need for us to go to the patient, especially in the rural, semi-rural, semi-urban areas. And second is, even in the urban areas, is it now time to give a favorable nod to home infusion? So can we have the discussion points, Arun? Yeah. So the first point. Yeah. So can I have Dr. Julka to comment on, are smaller daycare centers or chemo infusion points at PHCs, missionary trust run hospitals feasible? Will they be
Yes,
acceptable?
yes, I think they are acceptable. They would be acceptable because nowadays, in Delhi only, after we opened this center, Max Daycare Center, then many people started opening these centers. And they found that these centers are doing very well. People don't have to go far off. They are near their house and they are getting chemotherapy done, and then they go home. Now, the problem is in the rural setting, can that work? I am not sure, because rural settings we have a home care team in Max who do only palliative care at home. They don't give chemotherapy at home. So, but a PPP model can work. If adequate PPP model is there, it can jolly well work for this. And what would be the staffing for a typical daycare center? We have, what would be the training needs? Because we should have nurses, we should have front office staff, a small staff. We can keep about 25 to 30 staff, and with including doctors, both medical oncologists, radiation, and surgical oncologists who come and give just the advice, and then they can be sent to major centers for treatment. So there we can do a small tumor board, what we are doing in our daycare center, between all the modalities, and the treatment continues. So I think it is feasible, and more daycare centers have come up in Delhi, and I don't know about the other areas, but I think in Delhi all of them are doing very well, and they are in various localities. Like, for example, Defense Colony has opened one in Delhi, and after our center, but our center was the first one to be opened, and I started the center after my retirement from AIMS. So they pulled me from AIMS, and I started the center, and now more centers have come up.
Thanks, Dr. Julka, for that. It's really heartening to know that. And I must tell you on a very personal note, Doctor, I've always found you, from my early days in oncology, we used to love coming to you for visits, primarily
Yes,
because it would
yes.
be a learning experience. You know, the professor in you would not stop and you would really teach us the subject. So, so we always thought of you as a very innovative person. I remember launching immuno-oncology to you, and the way you would explain to us what the product was. So thanks a lot. I knew
Yes,
this would, there's a definite yes coming from you on this.
yes.
Dr. Dr. Bapna, your views
Yeah.
on this?
I am little bit sort of not really in favor of daycare center in the
Yeah.
any area where you do not have a qualified medical oncologist. So chemotherapy infusions are highly specialized procedure, as specialized as giving radiotherapy and doing surgery.
Hmm.
So for me, I'm really not in favor
Okay.
of such kind of practices.
Okay. Okay.
Rather,
Uh,
they should be abandoned.
okay. All right. You're saying they should be banned and we should not have such centers because there are not enough qualified people to look up to man these centers. Right, Dr. Bapna?
See the
Yeah.
medical oncology and giving chemotherapy is as specialized as doing surgery and the giving radiotherapy.
Correct. Okay. Hmm. Hmm.
So this should be always be given at a specialized center only. We should not propagate a message that it is such a casual procedure where which can be given anywhere, wherever you want.
Yes, I
Right.
agree with Dr. Bapna, but let me tell you that in all these centers which are working, they are all having DM in medical oncology from
Yeah,
AIMS.
sir, that's okay.
So,
If you have a qualified oncologist, there is no problem. But not
ah,
in the rural area as suggested by,
that is what I said.
No,
Rural
no, no.
areas, no,
Yeah. So,
because rural areas don't have, and Max as a home care team for every area, but for palliative care only, not for
yeah,
chemotherapy.
I think what the paper was suggesting was, and this point was taken from the paper, was that the staffing, the training, and the even the doctors there would all be. It would maybe a hub and spoke model. You know, you have, let us say, a tertiary care center feeding into RCCs, feeding into the district hospitals, so that it is their model which is replicated in these places, of course with a with qualified doctors being there. So that was probably what the paper was suggesting, Dr. Bapna. So I don't I think we can go through the paper again, and I don't think they were suggesting that we actually pick up physicians and say that, okay, now from tomorrow you give chemotherapy. No, it was more from the point of view of, yes, we need to have chemotherapy in these centers. Can we get doctors maybe on a rotation basis to go out there to those centers and look at administering chemotherapy to play in these places where the patient is? So that was probably what
So
the paper
look,
was
Satish,
suggesting.
that the
Yeah,
author and the co-author of that paper which you are quoting, whenever
yeah,
they issue a letter to
yeah,
the places wherever the patient belongs to, they always write in the end that it should
yeah,
always be given by a trained person
correct.
in
Right.
medical oncology. So there is a lot of contradiction in that paper. It
Okay.
need to be taken
Okay.
with a pinch of salt.
All right. All right. Got it, sir. Got it. Uh, can we move to the next question,
Let us
Arun?
know Dr. Shailesh Bondarde's opinion also and Poonam Patil's opinion also on this, whatever I have said.
Sure, sure, sure,
So
sure, sure.
we had now we are having food at home, shopping at home, dentistry at home. And this was the only thing which was remaining. Now you will
Mhm.
have chemotherapy at home. So everything at home. Everybody
Mm.
wants to go to the customer. You can say now we are into the Consumer Protection Act, and so everybody wants to go at the home and give the service. But who will take the responsibility? What if something happens at home? Who will take the responsibility? Do you want the medical oncologist to go at home, administer the chemotherapy, or you want his team to go at the home and administer the chemotherapy? And if you want to keep such an expert team, how much will you pay them? How much will the patient pay them if you go and give chemotherapy at home? Has anybody studied this structure?
Yeah.
That's what I want to say, Shailesh, that if we propagate this message casually, people will also take us casually.
No. This is absolutely wrong. You cannot do this. If something happens, then
yeah, I agree.
Yeah. So let me clarify, sir. We
If
are
you're
not doing
thinking
this.
of a hub and
This is
spoke
just
model, I can understand. I mean, I can understand that, you know, if, for example, I have a big center TMH in Mumbai, maybe it can we can work as a hub and spoke, and that's fine. That is workable. But not something like a chemotherapy at home.
So yeah, these were two different things. So the first one was the hub and spoke model, which was the paper which we were discussing till now. The second, I think, your opinion on chemotherapy on home based, yes, that is. I mean, I must admit that is the opinion of most of the people we speak to. We just wanted to see if over the period, we did a similar exercise somewhere in the month of April with a group of doctors. We posed the same question to them, and the answer was pretty much the same what we are hearing now. We just wanted to check if over a period of time, given the situation that we've all gone through the last 4 months, has anything changed? Home-based chemotherapy, there are few organizations which are doing it in India. They claim to have, I must tell you, it's a claim that there are qualified doctors who attend to these patients at home. There is a qualified chemotherapy nurse who attends to the patient at home, and it's also technologically linked to the main caring center. So that is the model in which this, or at least one of the organizations that we know of, is operating.
Will
But
the
it is
court
very
accept?
small.
Will the court accept that we were technologically linked and I was sitting in the hospital and the patient died at home?
Yeah, so that's what. So these are things probably which we need to look at. I know that in the city of Delhi there are a few doctors who use this home-based chemotherapy. Uh, there must be some legal route around it, I'm sure. Or maybe there is a risk stratification which is possible. That is what we're saying. So we are sitting on lots of data in each of these hospitals. Is there any which ways we could do a predictive analysis and look at, is there a subgroup? I mean, I would really look at all of you for answer. Is there a subgroup of patients who would be at least risk uh, of adverse events? Are there such subgroups of patients? And if there are such subgroup of patients, can this be considered an alternative? We are nowhere close to this. We are not suggesting that we will do this. We are just picking brains. We are just picking your thoughts on this and seeing, is there a scope for something like this going forward? Is the environment around us changing? All right. So that is all that we wanted to check. So any other opinions on this, Dr. Patil, Dr. Chatterjee, Dr. Prasanjit Chatterjee? Dr. Chatterjee?
Yeah, I missed a part of the
Hello?
discussion. Can you
Oh,
hear
I'm sorry. Yeah, I can hear you. Can you hear me? Because my network also seems to be fluctuating. Anyway, so we were saying, we were talking of home-based chemo infusion, sir. Your opinions?
Yeah, I think I missed it, but I think the purview of medico-legal issues has come up, and that is most important with the national consumer being so active. So how do we handle that? That needs to be addressed in a very legal format.
Okay.
See, there has been a lot of discussion, and there is now discussion about the consent, what we are taking about. The definition of consent, according to the highest court in India, that is the Supreme Court, has changed by a recent verdict which has come up. So this has to be taken with the ambit of the medical legal law and then thought about how it can be executed and implemented.
Got it, sir. I think that is also what Dr. Bandarde was saying. He was saying of the medico-legal issues. That is a serious concern that we need to address. I mean, that this whole concept needs to address. So thanks a lot, Dr. Chatterjee and Dr. Bafna, Dr. Bandarde, Dr. Julka, for answers to this question. Next point. Sorry,
Provocative.
yeah, provocative.
So it was the only question which has provoked all of us. And
no, sir. The intention was not to provoke. The intention was seriously to get some.
good that you have brought this point.
It was just to get some insight into this, and there are papers and papers written on all this, and some of this, it's like that oncotype DX question. We know for sure that it is not used right, left, and center. We know that. Every interaction that we talk about this, everybody has the same opinion. But we just would like to keep a track of any change that is happening in the environment. That's all. Nothing. Intention was not to provoke. All right.
For oncotype DX also, whether patient can afford it or not afford it, it's the patient problem. We need to clearly document in our file that we have counseled the patient about such kind of test.
Yes.
So the time has come that you need to document in your file.
That's right, sir. That's right. I mean, I know of a personal experience where where the patient refused to go for oncotype DX. Her relatives were forcing her. Her relatives based in UK were forcing her to take. But she said, no, I can't spend so much. And then finally the doctor said, see, whether you take it or you don't take it, the answer, as Dr. Patil said, would be, you choose your own, you make your own decision. So rather you don't do it. At the end of the day, if it is the patient who has to decide, all of this has a completely different perspective. So thanks, Dr. Bapna. That was a very interesting and invigorating discussion on this. Can we go to the next slide? Arun?
Dr. Patil probably wanted to speak something.
Oh, sorry. Dr.
Came on video and then.
Yeah, Dr. Patil.
Nothing. I agreed with.
I'm so sorry.
I agreed completely with whatever Dr. Bondarde and Dr. Ajay Bapna said. Even I would not agree with giving any kind of chemotherapy at home. I would also suggest that they go to a place where there are trained personnel.
Not even zoledronic acid.
Yes.
Okay.
Sorry, this has got stuck. I'll have to share it one more time. Sorry. Is it visible? Hello?
Yes, Arun, it's visible.
Yes, it is visible. Yeah.
So, Satish, are you there? We can't hear you. Okay.
We lost him, Arun. He's not there. Maybe he'll rejoin.
Okay, I'll take it.
You can start, yeah.
So even before coming to this section, there was just one more point we wanted to check with you, and I don't know what's the answer to that.
Yeah.
Actually,
Arun.
Okay. So Satish, you're there?
Yeah. I just came back. So am I audible? Am I audible?
Yeah, you are audible. Just one question which came, which I was just about to ask was, before we get into this, is that which we were discussing on the tiered PAP as well as the loan part of it, is in some cases there are some hospitals who take huge discountings from on most of the drugs. However, in many cases, they are not passed on to the patients. So, is there a way in which there could be some hospital also shells out and shares and gives some discount to patients, or are there those thoughts which are there?
This will never happen, Arun.
Okay.
This will never happen, Arun.
Okay.
I'm telling you. So we need to send directly the patient to either stockist or to directly talk to you people.
Okay.
Don't depend on pharmacy of any hospital. They have their own vested interest and will never compromise their revenues.
Okay.
Yeah,
Okay.
I'm telling you.
Yeah. Thanks.
Most hospitals are made for money making. It is not they're all the charitable hospitals.
Yeah.
Most hospitals, charitable hospitals, okay, or government hospitals, we can probably expect. But many corporate hospitals, they are a business. Actually, they are a business. And sometimes I feel that in our hospital also there are more HR people and more MBAs than MBBS people.
Fair point. Thanks for bringing that.
There can be a way, like nowadays with the MRP. Can I just pitch in?
Yes.
Yeah, sure, sir.
Can I just pitch in? Yeah. My suggestion was like, if you reduce that MRP and that whatever the cost price for the distributor or whatever the price which you deal with the individual pharmacy of the hospital, and that margin, if it is reduced, that is also, you people are in the industry, you know better. There are some companies who try to make a wider margin between the MRP and the selling price. So then you can offer the benefit to the patient by giving 1+3 or whatever different schemes. So that is the way forward, actually, where the actual benefit goes to the patient. So I think you industry also people know about it. But the government has taken initiative on that as well. They have reduced some fixed about the pricing. So I think that is the way forward.
Yeah.
Thank you. So
Thank you, doctor. Thank you, doctor.
Satish, sir. Yeah. Please take it forward.
Yeah, so we will just take it quickly now. I think we are very close to the end time. So we just wanted to have your opinions, and I'll go around the table now. I will not go through all these questions. I just want to know three things. How has Biocon been in these last 4 months of lockdown when we have not been able to physically come and meet you? Arun, I think, can you take up this slide?
Yeah. So,
hello.
So basically, we
because
just
I'm losing connection.
Yeah.
Because I'm losing connection. That's why.
Yeah. No worries. I'll take it. So we wanted to check with you that since we are not able to meet you physically, and everyone is trying to meet you virtually, so how has been our connect with you over the past 4 months? Did you find that we've been adequately touching with you all and meeting you and having regular discussions for our brands, for the patients? Or is there anything which you feel we missed it so that we correct that? So anyone can please unmute and if I'm audible. So Dr. Patil, Dr. Chatterjee, yes?
Yeah, I just want to say carry on.
No, you please carry on. Sorry.
Yeah, I would say that vacuum has happened for Biocon with the doctors and healthcare fraternity on more than one occasion. And I'm talking about East Zone per se, and I'm not very much aware what is happening in the other zones. So this 4.5 months was certainly a big vacuum from Biocon to the healthcare fraternity. It goes without saying. In all types of connection, whatever I mean, the virtual connection also. I don't know why, but it was very much apparent. So it is only for this ad board meeting that we got connected, or rather I got connected in this Biocon format. But why is it so? When I could see the other smaller companies and the multinational are trying to work up or catch up in at least for last 1.5, 2 months. So this goes without saying that Biocon happened to dip very badly, and you need to put your
Okay.
right foot forward.
Okay.
Yes,
That's
I think I would like to add to Prasanjit. I
yes, sir.
agree with him that Biocon has lost contact with the healthcare fraternity. Probably they didn't know because they were not visiting the centers, number one. Number two, what they could have done was virtual meetings with a few doctors in various cities. Different, cities, they could have done virtual meeting like other companies are doing. They did a meeting with me, the Pfizer, the other companies, they did a virtual meeting, and then they explained that we are going to launch, for example, Alpelisib was launched. So once it was launched, there was a webinar followed by virtual meetings with individual doctors. So I think Biocon should also take initiative in doing virtual meetings with doctors in every zone.
Okay.
For example, he said East zone, there was a gap. So gap was in every zone, more or less. So
Okay.
I think it's a candid discussion.
No. It's a candid feedback. Thank you. Thank you very much.
Yeah, sure. Thanks a lot. Thank you so much.
Dr. Patil, you wanted to
Yeah.
say
So
something?
can we look at?
No, nothing specific. Yes, for everybody, this period has been difficult, and we also have been missing you all. But yes, we do get an occasional phone call, we do get an occasional email, but we have not had any virtual meetings like how others have done.
Okay. Thank you, ma'am. Thank you. Yes, Satish, you were saying something. You want to? Hello?
No. It's okay. It's okay. I mean, each time I try to say something, I lose my connection.
No. You
So it's
can
okay.
speak.
I think, yeah. Am I? No,
So
Yeah,
we
yeah.
have gone round the table with that.
take all these comments as positive criticism. So
No,
this
no.
is all,
Yeah,
because
of course, of course.
we feel attached to you. So that's why we are, critically discussing it, and take it as a positive
Hello.
criticism.
Absolutely. We're taking
No,
it
for
in
sure,
a
for
very
sure,
positive
for
manner
sure.
because it will definitely help us fulfill that void or the vacuum which you just mentioned. So we definitely would turn it around and fulfill that. So that's the whole reason
Yeah. For
for
sure,
that
for sure.
question. So thank you for that.
Yeah.
So is there any
Next is.
suggestions you should give? Because from a WhatsApp standpoint, we've been trying to be in touch through the latest guidelines or whatever is happening. So those parts, that communication is very much on from our end. So is there apart from these virtual CMEs or the ad boards or panel discussions, is there any other format which you would like us to bring forward and engage with you and discuss things with you? So
I think psycho. Can I just pitch in?
yes, please.
Yes, as we were discussing, and it is an important issue so far as this psychology counseling. So,
Yes.
if you could provide a platform where our patients could be offered about this counseling, well, that
Yeah.
was there with most of the other companies from time to time. But this is
Mm-hmm.
the moment of crisis, and we feel most of our patients require that very badly. So that is
Okay.
the way forward. So you can help as a company, and where we can join our hands and the patients get benefited at the end of the day. So this is one of my, input where you can stretch your wings, and I think that can work out very positively.
Fair point, sir. So surely we'll go back to the drawing board and we'll definitely look at it and see what's best if we can do it. So, but that's a very good ask from your end for the patients. So thank you for that. Uh, Dr. Bafna, would you like
For
to
sure.
add?
No, I think what Prasenjit has said is absolutely correct, and my opinion is almost same as others' opinion. Be
Okay.
proactive. Be
Sure.
proactive, because it is a competitive world for the pharmaceutical companies.
Yes,
So be proactive. That's just that. Like,
absolutely. Fair point, sir. So thank you for that. And Dr. Krishna Kumar Ratnam, are you there? Is he there?
No, Arun.
Okay. Dr. Bondadi, are you there? Would you like to?
Yes, sir is there. Yeah.
Yeah, I echo the same thoughts actually.
Okay.
To be more aggressive.
On the psychological counseling part,
Sorry, I didn't get
uh,
it.
you echo the same thoughts on the psychological counseling
Regarding
part?
the connect you are discussing.
Correct. Okay.
Connect.
Correct. Okay. Fair point. So, one
Connect.
second. Again, my slide is, oh, sorry. Okay. Uh, and is there anything which you see, because since the reps are not able to meet physically, is there any role change which you foresee, which the industry should be doing for the pharma rep, and especially when we talk about our own organization? Uh, Dr. Chatterjee or Dr. Julka?
Yes,
Is there,
actually, pharma role would be in the form of, like the virtual connect, and then sharing the latest in every field. In the field of oncology, what is the latest guidelines or latest, you know, the recent advances in oncology. So, sharing that would update the knowledge of all the oncologists, the budding oncologist, as well as the senior oncologist also, because now is an era of precision medicine. And
okay,
for precision medicine, small things, I would like to just highlight, for example, hormone receptor positive breast cancer.
yes,
Now,
sir.
for that, if a patient gets resistance to CDK4/6 inhibitors, which we are using with hormones, so then we go in for PI3 kinase mutation. Now, what the other companies are doing, they are giving coupons, free
Hmm.
coupons to do these mutations. And once
Okay,
mutations are done, then the drug available is alpelisib. So, what I am saying is proactiveness on the form of in the form of getting all the latest data, the recent advances should be shared with the healthcare professionals, especially the oncologist. Every day we have a new thing. In head and neck cancers, HRAS mutation has been found. I
yeah.
don't know if you are aware of that HRAS mutation, and we have tipifarnib, farnesyl transferase inhibitors.
Mhm.
So this can be combined with biomap. So one should be updated in every field. So once you are updated, you can share the knowledge with the oncologist, and oncologist will be updated till the latest. Because I tell my students that yesterday or day before yesterday, this drug was approved by FDA. So this should be your motive.
Okay, great. So that's a very important.
That's very important, sir. Yeah.
Yes,
Thank you, sir.
Very nicely
those
said,
We
topics
sir.
which
should. We
Thank you,
should.
Dr.
And we
Julka.
will.
Nicely pointed out.
nice. So with that, I'd invite Dr. Meera to further bring it to the conclusion.
Yeah, Arun, yeah, next slide, please. So I think this slide is very apt now. So with all positive feedbacks, and we really owe this to you. Thank you so much for bringing those points. And we absolutely agree what you said, and we shall overcome with all these inhibitions and the drawbacks, which we probably unintentionally we went through, but we will overcome. So coming back to the again with the COVID situation, you will agree that there is a rat race for development of vaccines, and more than 160 vaccine candidates are being there in their various stages of development across the world. Out of that, 8 are from India. So 23 vaccine candidates are in clinical trial, and 6 are in late stages of development, which is in phase 3. And 2 are from India, if we talk about these vaccines. And you all must be aware of this Bharat Biotech and ICMR collaboration. And they said that by 15th of August, they will bring, of course, the time will tell that how much effectiveness they bring it. But of course, vaccine is the hope as of now, which people talk about the COVID-19 thing. One interesting piece, I know we are running short of time, but I will quickly just mention that in Spain, US, and Switzerland, they talked about the, sorry?
Go ahead, go ahead.
Yeah,
Carry
so
on, carry on.
they talked about that there is no herd immunity for this virus. And in Ahmedabad Municipal Corporation, they presented the data of 30,000 plus patients where the zero prevalence rate was ranging between 17% to 28%. So there is no hope as far as the herd immunity is concerned. And I understand even ICMR has done the similar study, which the results are still awaited with 500 samples. So that's where we are. And until we have the vaccines, we need to really struggle what we have in our hands. So from Biocon, I would want to share that where do we stand? And we were also in that race of bringing some solution to these patients, wherein we were having dearth of treatment options. Arun, next slide. So we repurposed some of our drugs, and we brought some of new drugs. Where we stand today, we have 3 actually solutions. We know that the spectrum of this COVID diseases, the mild disease, the pulmonary stage disease, and the critical illness disease. So in mild, we know that all these drugs are in the experimental stage, whether we talk about hydroxychloroquine, we talk about antiviral drugs. We have approvals now, emergency approvals for favipiravir and remdesivir. So we are in phase of getting remdesivir for the early stage of the disease. Then the moderate to severe disease, which is the pulmonary stage, the 70% of the fatality that happens in COVID patients is because of ARDS, and 30% is because of the CRS, the cytokine release syndrome. So to share with you, we have one drug which is called as itolizumab. This has been marketed in India from 2013 onwards for moderate to severe plaque psoriasis. This is anti-CD6 drug, and this inhibits the release of various cytokines, including IL-6, IL-1, IL-12, IL-10, and TNF alpha, interferon gamma, and so on, through Th1 and Th17 pathways. So we repurposed this drug and did a small trial because we didn't know how it will fare, but mechanistically we assumed that yes, this drug will work. And that's how we did trial in 4 major sites in India, the KM, Nair, LNJP, and the AIMS in Delhi, and where the randomization was 2:1. And we found that there was a statistically significant reduction in terms of mortality, as there were 3 deaths in the best supportive care arm, vis-a-vis no death in the treatment arm, which received itolizumab along with best supportive care. So we got restricted emergency authorization for this drug on 10th of July, and it is there in the market for patients who are having cytokine release syndrome and ARDS, moderate to severe ARDS due to COVID. So this is about itolizumab, and the cytosorb is a device, hemoadsorption device, which we were marketing in India for the sepsis, for absorption of various cytokines. And this also got the emergency authorization first from US FDA, and then followed by 6th of May from DCGI for critically ill COVID patients, wherein there is already a cytokine storm which is set in, and there this device is used along as a standalone, along with the ECMO and along with the dialysis, pre and the post dialysis setup. So that's where we have built in for COVID, the early disease for remdesivir, which is yet to come, for moderate to severe disease, the tolizumab, and for critical disease, the cytosorb device. So I'm happy to share these developments from our side, however, very positive feedback, and we definitely want to connect with you all more often and with more productive discussions. So I will hand over now to Satish Menon with this. It was pleasure connecting with you all. Thank you so much. Satish, over to you. So I think Satish, I don't know if he's not able to speak. Arun, I think you can cast the vote of thanks, please.
Yeah, I'm here.
Oh,
I'm
great.
here.
Great.
Carry on.
Yeah. So thanks a lot. It's been more than 2.5 hours that we've been in this conversation. A lot of insights on every aspect that we spoke of. We hope we are able to action some of these insights, and more specifically the feedback towards the end, which has come in terms of enhancing the connect. So thanks a lot, doctors, for having been here. Dr. Julka, Dr. Bapna, Dr. Punam Patil, Dr. Ratnam, Dr. Imran Sheikh, Dr. Shailesh, and Dr. Prasanjit. Thanks a lot for sparing your time and spending that time with us and giving us so much of insights.
Thank you to you all also for bringing us together.
Thank you.
Arun, Dr.
Thank you so
Thank
much.
you.
Dr. Neera, Mr. Arun, and Mr. Satish Menon. Thank
Thank
you
you.
very much for bringing us together.
Can we all come on the video for a minute?
Yeah, thanks.
1 second.
Okay.
Truly,
Okay.
thank you all. So this is also a stress buster for us.
Thank you all.
Yeah. Weekend distress buster.
That is what
Yes.
I told them.
Thank you so
Thank you
much.
so much. Thank you so much
Thank
again.
you.
Thank
Thank
you.
you.
Thank you so much.
Appreciate your
Thank you.
Thank you.
really appreciate your feedback and inputs. Thank you so much.
Thank you.
Thank you.
Okay,
Thank
bye.
you so much.
Be safe. Have a
Okay,
nice
bye.
evening.
Bye.
Bye.
Bye. Good night.
Good night.
Good night.